Welcome to the Royal College of Physicians Edinburgh Clinical Conversations podcast. Each episode within this podcast series, we delve into a different medical topic with an expert speaker to join us. If you want to find more about the Royal College, then please do head over to the RCPE website and have a look at the education stream and see if membership would work for you. It offers a host of educational updates and activities such as the evening medical update, the Royal College Symposia, and many more. Please don't forget, if you listen to our podcast, to give us a rating on one of the podcast platforms or subscribe so that it can come directly into your podcast stream.
Hello everyone, and welcome to another episode of Clinical Conversations brought to you by the Royal College of Physicians of Edinburgh Trainees and Members Committee. My name's Dr Marilena Giannoudi and I am on the Trainees and Members Committee, and today I'm delighted to be joined by Dr Sam Pearson, a consultant in diabetes and endocrinology at Leeds Teaching Hospitals. And today we will be talking about adolescent diabetes and technology, and type 1 diabetes as a whole. So Sam, good morning, welcome. Thank you for joining me.
Good morning, thank you.
I think the best place to start would be about the challenge of diagnosing the adolescent patient or the young adult patient with diabetes and what that kind of entails.
Yeah, certainly. So I think the best way to describe how the young adult service works is that we take referrals either from our paediatric colleagues, so patients who are already diagnosed as having diabetes, and we also obviously take referrals from primary care and from hospital inpatient setting, and that's where most of our referrals come from. So many of our patients that come to our service have already been diagnosed as having some form of diabetes, often type 1 diabetes, so that makes up more than 85% of our cohort, but we do have other forms. And in terms of a new diagnosis of diabetes in those in the age group of sort of 18 to 25, the first question that you have to ask for all of these patients is, could this be type 1 diabetes? So you have to ask that question first and then you work backwards, because missing a diagnosis of type 1 diabetes has got potentially disastrous consequences. So I think that has to be the first question to ask. In terms of whether they have got type 1 diabetes, you have to look through their presentation and what results are available. So if a young person has presented to hospital and they've got classic, what we call osmotic symptoms of weight loss, polydipsia, polyuria, and ketoacidosis, the diagnosis here has to be a clinical one of type 1 diabetes. Okay, so you would diagnose the patient at that presentation as a new presentation of type 1 diabetes and treat them as such. And the patient will be commenced on intravenous insulin to treat the ketoacidosis, and then later subcutaneous insulin once they're ready and discharged. So those patients are relatively straightforward. What we generally do now for all patients presenting with suspected diagnosis of type 1 diabetes is something called antibody measurements. So we measure some specific autoantibodies which are directed against the pancreas, and those are positive in probably 90% or so of patients with type 1. And we've now moved to testing what we call triple antibodies. So we measure GAD antibodies, IA2 antibodies, and ZNTA antibodies, so 3 antibodies. And basically, if those are positive, then it is very likely the patient suffering with type 1. So it's a confirmatory test. However, if patient have got a classic presentation with what we think is type 1 and negative antibodies, they still may have type 1 diabetes. So that's the really important thing for you guys to understand, is that you can have what we call antibody negative type 1 diabetes. So that's the sort of barn door, relatively straightforward diagnosis. The complexity comes when people are referred in a non-emergency situation and there's more of a grey area as to what kind of diabetes they may be suffering from. And the reason that this is becoming more problematic is that the weight is increasing of many patients, particularly in Western countries, but also in developing countries. So we're seeing an increased prevalence of type 2 diabetes amongst younger people that perhaps 20, 30 years ago weren't presenting. And it can be challenging to try and pick out whether they have type 2 diabetes, whether they have type 1 diabetes, or whether they have something else. So I don't know if that's something that you've come across, Marilena, but certainly people like this, they can present to on-call settings because they're seen by primary care colleagues with symptoms of diabetes. They're aged 22. And of course, the thing that the GP is wondering is this type 1? So these patients are presented through nearly always to a specialist diabetes service given their age. And the things to try and look out for in this context is weight, and more importantly, actually, what the trajectory of weight is. So if people have got diabetes and are obese, if they've lost a great deal of weight, you still have to be very suspicious that they may have type 1 diabetes. Okay, so if their weight is falling off, that's a concern that they may have a severely insulin deficient state. So it would be difficult not to treat those patients as having type 1, at least in the acute setting. The next thing to do is to look at things like family history. So is there a strong family history of diabetes pointing towards type 1 or type 2 diabetes? You look at the rapidity of onset of symptoms. So how fast does this patient develop symptoms? If they've developed rapid onset of, weight changes, etc., then again, you have to be very suspicious. In those patients, things like antibody testing is helpful, actually. So if a patient presents, say, with a HbA1c of 60 and they're not hugely symptomatic of diabetes, and actually many of our patients are picked up incidentally who have got type 2 diabetes, the test is done opportunistically for something else, then it's more likely that they may be suffering from another form that isn't type 1. So in that context, the antibody is negative, and then you can move on and make a clinical diagnosis, usually of type 2 diabetes.
Okay, I guess the first thing that comes to mind, which is really interesting, is the fact that you don't necessarily need positive antibodies to have a type 1 diagnosis. That's definitely something for me to remember, because in my head I thought you needed the antibodies.
So we've moved towards using antibodies more and more, but there are patients with classic symptoms and they've come into hospital with ketoacidosis. They're young, they're thin, there's no family history, and they have negative antibodies. So it can happen. It's relatively well described now, yeah.
So can I ask then, obviously you mentioned when you have this straightforward patient that comes in, osmotic symptoms, they are ketotic, you start them on intravenous insulin, that's fine. What happens in these patients in the grey zone when you're not sure whether it's type 1, whether it's type 2, do you just put them on subcut insulin whilst you wait for the results of tests, or how do you manage that?
So it depends really. So if they've got a degree of ketosis, the safest thing to do is to put them on insulin whilst you're waiting or pending further investigations. And the same is true if the patient is frankly symptomatic of diabetes with osmotic symptoms and weight loss and very high blood glucose. So, in that 15, 20, 25 range, usually the clinical risk is high. So patients are often commenced on insulin at that point with a suspected type 1 diabetes diagnosis. So remember, not everybody with type 1 diabetes will present with DKA. Maybe only 20 or 30%, something in that ballpark. So there's a significant percentage of patients who will present with symptoms but not ketoacidosis. So it's important that those patients are commenced on insulin early. This is for type 1 diabetes. The more challenging patients, as you alluded to, are the patients who present to an emergency setting but having been picked up incidentally, and that happens frequently. So for example, the patient has a urine infection, they go to the GP, they have a urine dipstick which shows they've got some glucose in the urine. The GP sensibly checks the patient's blood glucose and it's slightly elevated, say 10 or 12. So they're referred to hospital as possible type 1 diabetes given their age. And that is a difficult clinical situation to try and address, because obviously the benefit of putting them on insulin is that it's a safe treatment in case they have got type 1 diabetes. The risk is you're giving a very invasive treatment that the patient may not actually require. So for those patients, it's more of a decision-making process as to what you think the probability of them having type 1 diabetes on that day is. And if you have a low index of clinical suspicion, then it would be reasonable to commence some oral therapy.
And obviously, these patients, one autoimmune disease can predispose you to another one, or you have a higher likelihood of a second one. And I know that when I was on the acute medical unit, we had the same patients coming in that had uncontrolled diabetes and another uncontrolled autoimmune condition. So at what point do you test for possibly a second autoimmune condition? Is it at the time of diagnosis, or do you wait to see if their symptoms change and test then?
Yeah, so it's a good question. So some autoimmune conditions we test for very frequently. So hypothyroidism and celiac disease are tested routinely in patients with type 1 diabetes on an annual basis. So we check the patient's TSH. Often they'll have their TPO antibodies checked early on in their diagnosis, and we check their TTG for celiac disease. So we do that on an annual basis, and we pick up relatively commonly actually people with coexisting hypothyroidism and celiac disease. The other sort of conditions which are associated with type 1 diabetes or are in the sort of cohort is things like vitiligo, so skin disease, so you can see that obviously. And then Addison's disease is the big one that people are concerned by, because obviously like misdiagnosis of type 1 diabetes and misdiagnosis of Addison's disease has got potentially disastrous consequences for the patient. So Addison's disease is not something that we routinely screen for. So we don't routinely do like annual cortisols or synaptin tests. But if we have patients with type 1 diabetes who are having things like lethargy, weight loss, postural hypotension, uncontrolled or unexplained hypoglycemia, or pigment changes, so skin pigment changes, then we have a low index of clinical suspicion for Addison's disease. So we investigate early in patients like that. So it's more of an opportunistic type investigation, like commencing insulin in type 1 diabetes. If you think there's a good chance somebody's got Addison's disease, and this is for your listeners, if someone comes into hospital, they've got type 1 diabetes, they're hyponatremic, they're hypotensive, just give them steroids and then we can worry about the diagnosis at a later date. It's much safer and much better for the patient to give aggressive early treatment. Yeah, and then there's other rare endocrine disorders which are associated with type 1 diabetes, things like hypoparathyroidism, so hypocalcemia, very, very uncommon. We don't see that often, but people have got symptoms of things like tetany or muscle weakness or something like that, then we could opportunistically check their calcium and PTH to make sure they're not suffering with that. Yeah, I think that's about it, really.
And after, you've got the patient, new diagnosis type 1, you make sure they're not ketoacidotic. How do you then, what insulin regime to put them on, and at what point do you consider putting them on some sort of technology, whether it's a pump or something else?
Yeah, so good question. So long story short, the initial treatment of choice for patients with type 1 diabetes, in adults at least, is to commence them on an insulin regime called a basal bolus insulin regime. And basically what that means is the patient takes once or twice daily long-acting insulin, and there's lots of different long-acting insulins which are available, and it does depend on which hospital you work in as to what the recommendation would be. And that tries to mimic the body's natural physiological production of insulin throughout the day. So the body's always producing a little bit of insulin in order to try and control blood glucose. And then the patient is commenced on some form of rapid acting insulin to be taken before they eat. So that's things like Novorapid, Humalog, Fiasp. There's different insulins. And again, it just depends on a little bit on what you're working, which would be recommended. And again, that's to try and mimic the normal human physiology in people who don't have type 1 diabetes. So that's the best way of replicating it at the beginning. In adults, patients generally have a period where they're commenced on basal bolus, and then we look in the months or short years or, ongoing time after as to whether they may progress onto insulin pump therapy, okay? And the reason for that is insulin pump therapy is recommended in certain populations of those with type 1 diabetes in adults. So the most recent guidelines from NICE would suggest that people with a HbA1c of more than 58 or with recurrent hypoglycemia or planning pregnancy would benefit from a new special type of insulin pump, which is called a hybrid closed loop, which I'm sure we'll speak on shortly. So if they meet those criteria, then we'd look to try and put them onto this sort of treatment relatively early. The problem arises, Marilena, with regards to this particular technology, so hybrid closed loop insulin pump therapy. It opens up the treatment to a huge number of patients who potentially wouldn't have been eligible on the NHS for pump therapy in the past, which has got problems for healthcare teams and healthcare services in terms of starting that number of patients on quite an advanced treatment all at once. So basically the plan from NHS England, which is reasonable, is to roll this out over a period of about 5 years. So patients with type 1 diabetes in the UK, which is fantastic, will be able to have access to this treatment in the next 5 years, or most patients. We don't know exactly what percentage will qualify, but it's going to be high. So that's it really. In adults, yes, we would look to do that if they meet certain criteria, and ideally early. In pediatrics, it's slightly different actually. So now the NHS is recommending that pump therapy is available for all children really who have got type 1 diabetes, and some of our colleagues in pediatrics commence pumps as an inpatient at first presentation of type 1 diabetes. So there are children who are being diagnosed as having type 1 diabetes today who may never experience injections, which is fantastic, really. It's a huge step forward, but I guess all different hospitals will act in different ways, but that is happening in some hospitals that I'm aware of, that they're treated, initially with intravenous insulin or whatever, commenced on a pump, and they're not given routine injections. They're obviously educated on how to do that, or their families are, but they may experience a life without injections, which is, compared to where we were 10, 20 years ago, is a fantastic step forward. Yeah, so that's pump therapy. And then other forms of technology. So the other arm of technology is continuous glucose monitoring. So this is a device which measures your blood glucose. It doesn't administer insulin. It just measures your blood glucose. And it does so by measuring something called your interstitial fluid, which is essentially the fluid which bathes the cells. And there's lots of different types of devices which are available, but basically this thing called continuous glucose monitoring is available to everybody with type 1 diabetes on the NHS, so everybody can have it, and we commence that early, usually as an inpatient actually. If they're first diagnosed with ketoacidosis, for example, they're commenced on it that day or, in the coming days. And the benefits of continuous glucose monitoring are enormous in that the patient will know what their blood glucose is at all points. So they can make much more informed decisions as to what to do with their insulin, what to do with food, what to do with exercise, etc., etc. And it also allows the patient to have an alarm, which they use on their phone or on a reader that comes with the device, which will go off if the blood glucose is high or low. So if you imagine if you're a young patient and you're out playing football and then your phone alarms to tell you that you're about to go low, you've got time then to give yourself some sugar or to give yourself a snack in order to prevent you becoming hypoglycemic. So it's got huge benefits for reasons like this.
And obviously this is completely transforming the way we treat type 1 diabetes, but I guess most importantly how these patients are living, and it's giving them a more normal life.
Yeah.
But what are the possible complications, or are there any complications or any side effects
with using the continuous glucose monitoring?
Either with the continuous or with the pumps?
Yeah, so continuous glucose monitoring, yes, it's not without fault. So there is an accuracy range. So there's lots of different ways of measuring how accurate these devices are, but basically they're getting better and better. And what they call the mean absolute relative difference, which is a statistical marker of looking at how accurate the system is going down and is now about 10% or just under. So most of the commercially available systems will give you a reading compared to capillary glucose within 10%, which is good. Other potential side effects are they can fall off and you have to replace them. So most of them are worn for between 7 and 15 days, depending on the brand and the type of sensor that you use. They can have inaccuracies, as I alluded to, particularly overnight. That seems to be an issue where people are lying on the sensors. They can fall off or become painful, and they can become infected. So the sites at which the patient wears the sensor can develop infection because obviously they've got a foreign object essentially, which is having a small cannula and breaks the skin. So that is a risk. The other major thing that we see quite frequently is sort of contact dermatitis or other skin manifestations due to irritation from the adhesive, which is on the device. So those are the major sort of problems that we see with the continuous glucose monitoring. Pump therapy in terms of side effects. So most of our patients are now going on to this thing called hybrid closed loop pump, which is really quite different. And basically what that means is that the continuous glucose monitor that the patient wears is in constant communication with the pump. So the insulin is adjusted depending on what the blood glucose levels are doing. So what that means is, say the patient is walking to work and the blood glucose levels are falling, the pump understands from the glucose sensor that things are going down, so it starts to give less insulin. So that's got a hugely beneficial impact for the patient in reducing hypoglycemia, but also reducing hyperglycemia because it does the same when the sugars are rising. The problems with hybrid closed loop pump therapy is the pump can fail, the sensor can discommunicate from the pump. Again, you can get infection and site reactions where the cannula is sited. Other problems, things like the pump is trying to deliver insulin at a rate which is so high, what we call exits the automated mode, so it reverts back to the manual mode. Again, I'm not sure how useful that is for this audience, but it's not a cure for type 1 diabetes, basically, is what I'm trying to allude to. It can dramatically help people's blood glucose, both highs and lows, but unfortunately we're not at a position yet whereby the patient puts the pump on and that's it. They don't have to do anything else. It doesn't work in that way, Marilena. It still requires quite a lot of input from the patient, particularly around things like meal times. So the patient still needs to tell the pump that they're eating, and it needs to tell them how much they're eating, which for some people can be quite challenging.
And in terms of myself or my colleagues, if we see someone on MAU that's come in, with possible pump failure, what are the kind of basic things that we should be thinking of whilst we wait for an endocrinologist or one of the diabetic specialist nurses to come and help us?
Yes, I mean, pump failure is actually relatively uncommon. So people coming in with ketoacidosis who are on an insulin pump, it's possible it was a real issue related to the pump. I'd still be open-minded that there could be something else going on, like forgot to give the insulin, pump was not connected, patient's poorly, they've got a virus, they've got a bacterial infection. So be open-minded and don't necessarily assume that the pump is the issue. The first thing to do is, if the pump is failed and the patient's got ketoacidosis or has got true DKA, then they should stop the pump and they should be commenced on DKA protocol via intravenous insulin and rehydration. So that's a no-brainer. That's the treatment that the patient requires. If the patient's hyperglycemic and the pump has failed, or if they think that the pump's failed, the first thing to do would be to try to resite. And that would be usually patient-driven. So the patient would have to do that and try using a different cannula and changing the giving set. Or if they're using what we call an omnipod pump, to replace that. And then they'll need to give themselves a correction dose of insulin using that. If that doesn't work, then the advice would have to be to use pens, to use injections of insulin as opposed to the pump, pending specialist review. So for example, the patient comes into hospital. You've got a young patient who's on an insulin pump. They've tried everything at home to get their blood glucose down. They've changed their giving set. They've given themselves boluses of insulin via the pump. They present to A&E and they're hyperglycemic, but not in DKA. The best advice I'd give you is to give some correction doses of insulin using pens in that setting.
Okay. And my other big, I guess this is quite a personal query, but I'd like to see that the audience wants to hear about this as well, is that obviously a diagnosis of a long-term condition, somebody of that age, can actually turn their life upside down. And I think it can be quite difficult to deal with emotionally.
Yeah.
How do you deal with that to ensure that you've got good compliance and to ensure that we try and prevent long-term complications from an uncontrolled glucose in their teenage years?
Yeah, so it's a great question, Marilena. To be honest, it's one of the most difficult things about living with type 1 diabetes is the fact, probably unlike any other illness really in many regards, in that it's with you all day, every day. You have to think about it all of the time really if you really want to have perfect blood glucose control, which is incredibly difficult to live with for anybody, but particularly, as you can imagine, for younger people who have got a more erratic lifestyle. So for example, if you're doing sports, if you go out eating with your friends, if you go out drinking alcohol with your friends, these things all impact your blood glucose, so it requires constant thought. So exactly as you alluded to, it can have a huge psychological burden. And it's really important that all of us who work in healthcare are very empathetic towards those with type 1 diabetes, because it's very, very difficult illness to live with for many people. In terms of how we approach that, I think the most important thing is to explain to the patient that, yes, we understand it's very difficult, and not to be judgmental, not to be critical when you see them in the clinic or in an inpatient setting when, they've forgotten to bolus their insulin or they've forgotten to do whatever. Because if you imagine, if you're a medical student or if you're a junior doctor or if you're anyone working in healthcare, if you wake up in the morning and you haven't got type 1 diabetes, but, say tomorrow you're given the diagnosis of type 1. You wake up in the morning and one of the first things you think about is, oh, what's my blood glucose doing? Then you have to bolus before you eat your breakfast. You have to match exactly how much insulin you take to how much breakfast you eat. Then you walk to work, you might be at risk of going low, so you have to augment what you're doing in that regard. Then you're doing a ward round and then you go a bit high and you have to take some more insulin. So you can imagine how difficult it is for these patients. So I think empathy is the most important thing really that I would advocate for. Of course, something that can be beneficial and that we would advocate for is psychological support for anybody with a long-term health condition really, but particularly in our younger patients with type 1 diabetes, we work closely with our colleagues in psychology services who can provide support for these guys. And we actually, in our service, have got some psychologists who specialise in management of patients with type 1 diabetes and the burden that may entail. And they are invaluable, really, in trying to support these patients. And then I think the other thing which is important to get across is many of these patients have coexisting other mental health problems, and that's more common actually in those with type 1 diabetes. So people with type 1 diabetes are at increased risk of things like anxiety, depression, and certain eating disorders as well. So some potentially very severe mental illness is heightened or an increased risk in this population. So it's important that you keep an open mind and keep an eye out for the coexistence or the emergence of these illnesses in patients who you're seeing. So it's something that when we speak to them, we often go through a basic mental state examination to try and work out how they're doing really aside from the diabetes and see what support or referral onwards we may require for them.
So do all patients have open access to the psychology services, or do you have to refer them if you're worried?
Very much depends on the centre that you work in, Marilena. So psychology support for those with long-term health conditions is difficult to find actually on the NHS in some settings. You work in cardiology, don't you? And, people with heart failure or whatever, they may not get the psychological support that perhaps they may require. And the same is true actually of diabetes. But in our centre, specifically for younger people, we do have available psychological support with 2 specialists, but that isn't uniform across the condition and certainly across other hospitals. So it's something which is lacking in all aspects of chronic health management in the NHS, I think, actually.
And how often do you see these patients? Because I know that you work as part of a large multidisciplinary team, and you said the psychologists, the dietitians, the nurses, the podiatrists, and the list goes on. But how often do these patients need to see the consultant endocrinologist for their management?
Yeah, so ideally, the younger guys, so those between the ages of, say, 18 and 25, would be seen 3 to 4 times a year. Whether that's always achievable or whether it's always achieved is another question, but that would generally be the recommendations and what we would strive towards. Like any part of adult medicine in the NHS, there are limitations with regards to how many appointments we have available compared to how many patients we have to see. But generally, that's what we would strive for. And part of the reason, Marilena, why we look after this group in a slightly different way than we do older adults with type 1 diabetes is that we know HbA1c, which is a marker of glucose control, rises significantly in the sort of transition process. So when people are, say, between the ages of 18 and early 20s, the HbA1c is likely to be the highest it will be for their life. And what we also know from lots of very comprehensive research studies is that can have what we call legacy effect on their risk of complications moving forward. So, for example, if a patient who was 18 had a HbA1c of 80 for 5 years or 8 years, and then they got into their mid-20s or early 30s and then managed to reduce their HbA1c fantastically down to, say 50. Unfortunately, those few years where their blood glucose control was very erratic and their glucose was high does increase their risk of microvascular, particularly complications. So that's why there's a big move in the diabetes world to try and support these youngsters as much as we can to bring down their HbA1c and to improve their blood glucose control. And regular contacts is part of that, as well as things like psychological support and crucially technology, which we alluded to earlier.
And then when they're fully within the adult service, is it just once a year that you would see them?
It really depends, actually, and also within the patient. So, for example, if you have a patient whose HbA1c is 52 and they've had type 1 diabetes for 20 years and they've got no complications and they're on an ACE inhibitor and they're on a statin and they're very confident and well educated with regards to the management of their illness, we would probably see them annually or perhaps biannually. For a patient who's really struggling with their diabetes or with their renal disease, or they've got active retinopathy or they've got cardiovascular disease, we would see them more frequently, 3 or 4 times a year, whatever would be indicated in that context. So I wouldn't say there was such a regimented process in that regard, but in our hospital, at least, everybody with type 1 diabetes in our local area is generally offered hospital follow-up. So it is a condition of lifelong secondary or tertiary care follow-up, yeah.
Perfect. I think that's the end of my questions. I don't know if you have any final thoughts for our listeners about how we should be effectively treating these patients before you get to them.
As I said, my sort of take-home messages are whenever you see anybody with diabetes and you diagnose it, the first question to work back from is, could this be type 1 diabetes? And that's true of any patient of any age, but the risk is, of course, higher in those who are younger. And then the second thing, I think, more than anything else that you guys need to understand is just how difficult it can be to live with a diagnosis of type 1 diabetes and how much that can impact on a patient's life and on their quality of life. So when you see patients coming into hospital, for example, with ketoacidosis, and you saw them come in last week with ketoacidosis, it's really very important that you're empathetic towards them and try and get to the bottom of what the root cause of the issue may be, because overwhelmingly when you see people with recurrent hospital admissions due to diabetes, there's a very high chance there will be something else going on in their life which is making it difficult to live with the illness. So it's important to try and explore their social situation, their relationships, etc., at that point. Because if you can get to the bottom of that and try and support them in that, there's a good chance you'll improve their physical health at the same time.
Great. Thank you. Thank you so much for your time, your wisdom, and for telling us everything we need to know about type 1 diabetes and technology. Thank you so much, Sam. And listeners, thank you for your continued support, and we hope you'll join us next time. The T&MC sister podcast, Career Conversations, supports medical students and trainees with career guidance and progression, as well as professional development. We wish to recommend our Demystifying PACES podcast series on career conversations. As some of you may know, in late 2023, MRCP UK updated the PACES exam format, so we developed this new series to support PACES candidates. Episodes cover exam organisation, calibration, every PACES station including key changes, and candidate perspectives.